Hello, my name is Paul Minkin, and I'm a professor in the physical therapy program at the University of Colorado School of Medicine. The purpose of this lecture is to introduce you to physical therapy classification and the management of low back pain. So, a little background. Physical therapy's vision is transforming society by optimizing movement to improve the human experience. And we really view ourselves as movement experts, and our expertise is in diagnosing and treating individuals of all ages with medical problems or other health related conditions that limit their abilities to move and perform functional activities in their daily lives. Now, if we talk about low back pain, this is an area that physical therapists are extremely passionate about. We know that low back pain is an extremely prevalent condition. Up to 80% of individuals will have back pain at some point in their life. Only 25% actually seek care, and up to 60% of the population will have had back pain in the last year. Unfortunately, with a new onset of back pain, up to 40 to 60% still report symptoms a year later, and this creates a tremendous burden on the healthcare system because up to 85% of people with a new onset of back pain will have a recurrence of their back pain at some point in their life. Now, the traditional medical model of disease, which has worked well for the past few centuries, in which you identify a pathology, you find the correct treatment, so let's say an upper respiratory infection, you find a bacteria that's responsible for this, you prescribe an antibiotic that clears up the infection, and the symptoms go away. And this model has been applied to low back pain using imaging as the way to determine the pathology. But unfortunately, this has failed because we know that pathologic findings are extremely common in asymptomatic individuals. So if we look at low back pain itself, unfortunately, it's a condition with no specific biomarkers, and only about 15% of low back pain can be given a specific pathoanatomic diagnosis. Now, we can certainly find things on imaging, but the question remains, is that the pain generator for the patient that's sitting in front of you? And this results in grouping the rest of these individuals into a big homogeneous group of low back pain, where any treatment is equally likely to succeed or to fail. Now, we know that pathoanatomic findings are extremely common in asymptomatic individuals. Up to 1 in 5 meet the criteria for lumbar instability, and only about 36% of individuals have a normal disc at all levels in their lumbar spine. And mild scoliosis, disc degeneration, and spondylosis are as common in asymptomatic individuals as they are on people with low back pain. So a pathoanatomic approach to low back pain has largely failed, except for a few very clear-cut conditions such as instability from fracture, spondylolisthesis, and let's say a massive disc herniation compressing the nerve root with neurologic signs. So focusing on providing a magic bullet directed towards a presumed damaged structure or biomechanical fault, or on providing symptom palliation has led to an exponential increase in imaging to identify these damaged structures, which has led to escalating rates of opioid prescriptions, injections, and spinal surgery, all of which have limited long-term efficacy and carry significant health risks. Abelson estimated that fewer than 1/2 of all lumbar surgeries are appropriate based on current guidelines. So this is in spite of evidence that abnormal MRI findings are prevalent in the asymptomatic population and are poor predictors of future low back pain and disability. Indeed, providing a patient with a pathoanatomical diagnosis can result in increased fear and iatrogenic disability. And I would argue that we're wasting our time and hurting patients with low back pain even more by obsessing about MRIs, posture, spinal stability, because providing a patient with a suspected pathoanatomic diagnosis may do far more harm than good. We need to change our thinking to embrace more of a biopsychosocial model by learning to motivate and understand our patients to enhance their self-efficacy, which ultimately leads to the best outcome. Waddell had this great quote in 1998: treatment of back pain according to the disease model has failed because there's a fundamental flaw to the approach. The disease model views back pain and disability only in terms of spines and physical disease. It does not allow for the complex human responses to pain and disability. So this biopsychosocial model embraces everything that the individual is having to deal with, including their social environment, the illness behavior, how they project to the world that they may be suffering, psychological distress, as well as their attitudes and their beliefs. And he had this great quote as well: low back pain disability depends more on fear avoidance than on pain or physical pathology. The fear of pain is more disabling than the pain itself. So if we can address that fear, we can improve the outcomes in a huge number of our patients with low back pain. One of the common things we see is these fear avoidance beliefs, where they start to avoid movement, which leads to impairments in mobility, strength, and fitness, central sensitization, peripheral sensitization, and misinterpretation of pain sensations, and exaggerated pain and increased disability. So I think where physical therapy plays a huge role is turning patients that avoid their symptoms into individuals that confront their symptoms, giving them a strong desire to return to normal activity, to move, to exercise, to confront pain barriers. This leads to an accurate interpretation of pain sensations and minimizes illness behavior and disability. So an alternative approach really started in the late 1990s with an agenda for primary care research on low back pain, where they signaled that we should really work on identifying different varieties and subgroups of low back pain, including criteria for membership. A meaningful method for patient subgrouping could improve the power of clinical research, because previous research had not attempted to identify which patients actually need the treatment being studied in physical therapy, for example, manipulation or exercise or traction. So the key questions are: which treatments really are effective for some patients, and what are the characteristics of the patients that need a particular treatment? For example, if we look at manipulation, if it was indicated for a large proportion of individuals with low back pain, if we did a randomized controlled trial, we would see a significant effect. Unfortunately, that's not the case. Manipulation helps some patients, but not all patients with low back pain. So if it is only indicated for a small proportion or a subgroup of individuals with low back pain, if we do a randomized controlled trial, there will be a washout effect. It'll help a subgroup, but that will be washed out by the rest of the people that don't benefit from the intervention. So in classifying individuals for low back pain, we really want to come up with specific criteria of individuals that will benefit from a specific treatment. Sikorsky had this quote in 1985: "It's rare to find anyone with a clear idea of what form of physical therapy is indicated for which type of back pain. The situation takes on the characteristics of a lottery. With the treatment left to the whim of the therapist, it's not surprising that the results are often poor." So Steve Rose started to talk about classifying individuals in the 1980s, and he defined this as classifying clinical data into named categories of clinical entities for the purpose of making clinical decisions regarding the actual treatment or therapeutic management. So Tony DeLito in 1995 published the first treatment-based classification on the management of individuals with low back pain. So the first level of this classification, or there are actually three levels of going through this process. The first level is, does the patient need rehabilitation at this point, which is a question for a whole separate talk. The second level then is, what is the level of acuity, or how do you stage the individual? And finally, the third level is, what treatment or what classification should be prescribed for the individual sitting in front of us. So at that first level, obviously you're going through a triage. Are there any red flags or yellow flags that may complicate or preclude treatment at this point? If they do meet the criteria for rehabilitation with lumbosacral symptoms of primarily mechanical origin, you would move to the next step, which is staging the individual. Now, this is not time-based, at least in physical therapy, we look at this at more from a functional limitation and participation standpoint. So higher levels of disability would be more in the acute stage, but this could be an individual who's had symptoms for quite a long time. So in stage 1, these would be higher levels of Oswestry scores, inability to sit or stand or walk for minimal amounts of time or distance. Stage 2 then would be lower levels of disability, and finally stage 3 would be individuals who can do most tasks but just cannot do very demanding tasks, such as a high-level athlete. So finally, we get into the third level, which is actually classifying into treatment groups. Now I'm going to go through each one of these 4 in a little bit of detail, highlighting some of the landmark studies, but keep in mind there are dozens of studies behind each one of these classifications. If we look at manipulation, the research has panned out that there are 5 criteria that tend to predict a good response to manipulation. And this is no symptoms below the knee, a recent onset of less than 16 days, hypomobility or stiffness in the lumbar spine, low fear avoidance like Waddell talked about, and then more hip internal rotation. So the landmark study that kind of led to these criteria was Tim Flynn's clinical prediction rule in 2002. He derived it in 2002, and this was validated in 2004 by John Childs, and then a subsequent study further built upon the validity in 2009. So basically they took every patient with low back pain, did a comprehensive history and physical examination, and then they manipulated everybody. Their criteria for success was a 50% reduction in disability within 1 week. If they met that criteria, they were a success. If they didn't meet that criteria, they were not a success. So 45% of the individuals in that study met the criteria for success. So then they looked at those individuals, what did they have in common that predicted this success compared to the ones that were not successful with the treatment. And this is where they came up with these 5 criteria: the recent onset, low fear avoidance, no pain below the knee, lumbar stiffness, and good hip internal rotation. If they had at least 4 of those findings, the post-test probability was 92% of a successful outcome, which again was a 50% reduction in disability within 1 week, with a positive likelihood ratio of 13.2. Julie Fritz then went on to analyze the derivation and validation study and look at which factors were the most strongly predictive of success. And she found that the recent onset of symptoms less than 16 days and no pain below the knee, if an individual just had those 2 findings, they had a 91% chance of success. So this is very easy to screen for in clinical practice. Now, many of you are saying, I don't see patients who have had pain for less than 16 days. But this really goes to primary care management. If primary care physicians would refer these patients to us early, the outcome would be a lot better, and I'll talk a little bit more about that later. Here's the manipulation that was used in the Tim Flynn clinical prediction rule. That's Tim Flynn in the video. It's a very simple technique. Primary care providers and physiatrists can do this technique in the clinic. It only takes a few seconds to do. It involves lumbar side bending, and then rotating from the top, placing them on their shoulder, pulling up on the shoulder so you're maintaining side bending and rotation, and then pushing down on the innominate right there. Very simple technique, tolerated very well by most patients with low back pain. We'll move on now to stabilization. So the criteria from the research that would suggest an individual may benefit from this treatment approach would be a positive prone instability test and aberrant motions, which I'll show you pictures or videos of those. Hypermobility, so in contrast to the manipulation subgroup where they have stiffness, these are patients that tend to have a little bit more mobility in the lumbar spine. They tend to have a younger age of less than 40 and greater straight leg raise or hamstring flexibility higher than 91 degrees. So there was a clinical prediction rule that was performed for this in 2005 by Greg Hicks. He took all individuals with back pain. Everybody got the same treatment approach, the stabilization approach, 2 sessions for 8 weeks, so 16 sessions. And then they looked at who was successful, a 50% reduction in disability over the course of that 8 weeks. And before they looked at any of the data, 33% had a 50% reduction. And if they had 3 or more of these findings, a positive prone instability test, aberrant motions, straight leg raise greater than 91 degrees, or age less than 40, the successful outcome doubled to 67%. So here is a video of the prone instability test.
Prone instability test is used to determine if muscle activity is needed to help stabilize a painful lumbar segment. Prone instability test consists of 2 parts. The first part involves PA mobility testing of the lumbar spine. If pain is elicited at a lumbar segment during testing, the level at which pain is elicited is noted, and the test progresses to the next step. The patient lies prone on the edge of a treatment table with the feet touching the floor. The pelvis should not be supported by the table. The clinician positions his hands over the vertebra that elicited pain during PA mobility testing. The patient is instructed to lift his feet off the floor. He should only lift his feet a few inches. As the patient holds his feet off the floor, the clinician applies a PA force through the vertebra. If this is less painful than the original PA testing, it is a positive prone instability test.
Now, as far as aberrant motions, what I teach my students is if you have them do a forward bend and return from forward bend, if it just doesn't look right, it's an aberrant motion. So here would be some examples.
Motions. Ask your patient to flex his spine and to extend it again. Different authors describe that pain during the movement to flexion and back to extension, the presence of the Gauss sign, which is when patients need their hands to come up into extension again, sudden accelerations or decelerations during the movement, a deviating lumbopelvic rhythm, lateral flexion or rotations during the movement can all be indicative for LSI.
So again, those are the 2 main criteria. Now this study was, there was an attempt to validate. Now all factors did not validate in this follow-up study by Rabin, but they did find that if individuals had those 2 findings present, prone instability test and aberrant motions, the likelihood of success with a stabilization approach increased to 80%. Now we'll move on to specific exercise. So this is classically either the McKenzie extensions, prone press-ups, or Williams flexion exercises. So these would be individuals with back pain with some radiation into the leg. Ideally, you would identify a directional preference. So they either like to stand or sit better. So individuals who have a directional preference for flexion will prefer sitting. Individuals with a directional preference for extension will prefer standing and walking. So the best study that illustrates the validity of this classification is a study by Audrey Long, who was trained by Robin McKenzie, who kind of came up with the prone press-up paradigm. And she looked at the role of these patient-specific exercises. So she had 312 patients and identified a directional preference. They either like flexion or they like extension, randomized them to receive either the range of motion exercise that matched their directional preference or what felt better to them, or exercises that were opposite. So if flexion felt better, they got extension exercises, or non-directional exercises, which were basically just side gliding the pelvis and standing side to side. So not flexing or extending. They looked at quite a few different outcome measures, including pain, disability, medication use, depression, that type of thing. And what they found was, here's the white line here, is the individuals that received the range of motion exercise that matched their directional preference. And this was significantly better on all of these outcome variables: pain intensity, leg pain intensity, the Rowland-Morris, the number of medications taken per day, depression, and interference with activity. Interestingly, in the individuals that were randomized to the range of motion exercise that was opposite their directional preference, 1/3 of those individuals dropped out. They said, this is making me worse, and I'm not going to continue to do this. So this clearly shows that giving patients exercise that match their directional preference can improve the outcomes. Finally, the traction subgroup. Julie Fritz commonly refers to these individuals as having 1 foot in the operating room. these are probably surgical candidates. These are patients with back pain, with radiating leg pain, with some neurologic symptoms such as myotomal weakness or sensory changes or reflex that's diminished or absent. And then the other findings that I'll talk about is a study she did where she found that individuals that peripheralized with extension or had a positive straight leg raise tended to do better with traction in the short term. So this is the study looking at traction. It was 64 patients with signs of nerve root compression, as well as back pain and leg pain. They were randomized to receive extension exercises on the top here, or extension plus 2 weeks of mechanical traction at 40 to 60% of their body weight for up to 12 minutes. Now, she did find that not all patients improved with this, but the two groups that seemed to have better outcomes were the ones that had peripheralization with extension movements. So that would be when they went into extension, the symptoms would shoot down their leg. Now, usually these individuals have massive disc herniations and they peripheralize with all movements, flexion, rotation, side bending, as well as extension. So these are individuals who don't meet the specific exercise criteria because you can't find a movement that centralizes their symptoms. So the only option available then would be to introduce some type of traction to pull the vertebrae apart and decrease the compression on the nerve root. The other group that seemed to have better outcomes was those with a positive crossed straight leg raise. And we know that the positive crossed straight leg raise is a very specific test for disc herniation. So this would suggest individuals with probably larger disc herniations, maybe extrusions or sequestrations, may benefit from traction as a treatment. Now, the other thing to keep in mind with the treatment-based classification is that it is a fluid system. An individual can move from one classification to another, or they may benefit from more than one classification type of treatment. So the big question is the TBC valid? Will effect size increase if matching occurs? Gerard Brennan published this article in 2006, which received the Rose Award, which is for the best orthopedic physical therapy article of the year. And in this study, they took 123 patients with back pain, excluded those with previous surgery, current pregnancy, or signs and symptoms of nerve root compression. Because that traction subgroup is small and typically, the prognosis is not as good with those individuals. And they randomized them into treatment 2 times a week for 4 weeks and looked at whether they received matched treatment versus unmatched treatment and reassessed them at 4 weeks and at 1 year. So if they met the criteria for manipulation or manual therapy and they received a matching treatment, they looked at those individuals versus the ones that were classified as manipulation but got either stabilization or specific exercise and so on. And what they found was there was a statistically significant difference at both 4 weeks and at 1 year in the individuals that received the treatment that matched their classification. Now, they did look at the reliability between Gerard Brennan and Julie Fritz in this study, and it was over 90%. They agreed on the classification over 90% of the time. And data from Intermountain Healthcare, where Julie Fritz and Gerard Brennan work, on over 25,000 patients managed with the TBC, shows that their outcomes are pretty good overall, and they average around 6 visits per episode of care. So looking at the reliability and validity of the TBC, the overall agreement between examiners in a study by Henry was 75.5% with a kappa of 0.6. In a study by Stanton, they showed that about half of patients with back pain neatly fit one of these classifications, 25% fit one or more, and 25% don't fit any. So the classification system at this point is not mutually exclusive, but it's improving, as research continues here. And then finally, validity. If you let the PT do whatever the heck they want with the patient versus using a treatment-based approach, the TBC results in lower costs, increased effect size, and significantly better outcomes for pain and disability. So in summary, in PT, a treatment-based classification results in lower costs and better outcomes. Seeing a PT early or first reduces the odds of advanced imaging, injections, surgery, opioid use, emergency department visits, and lowers out-of-pocket expenses. So in physical therapy, we want to see these patients. So we hope you'll give us a chance and send your patients to us. Thank you very much.